Primary hemostasis, Part 1. Welcome to the topic hemostasis. In this series of Chalk Talk episodes, we'll present the physiology of hemostasis, but we'll also go one step further and provide links to the most important conditions and drugs. Before we delve into the details, let's take a look at the big picture. Thrombi can form in the arterial and venous system. However, there are differences in drugs used in the prophylactic treatment of thrombi. The key message that we'd like to deliver is the following. In atherosclerotic diseases, platelets play an important role in initiating coagulation. Arterial thrombosis can, therefore, be prevented using antiplatelet drugs such as aspirin. Platelets are also present in the venous system, however, they play a minor role. The predominant feature of the venous system is the relatively slow blood flow rate, which poses a risk to spontaneous fibrin thrombus formation. Therefore, venous thrombosis is best treated using anticoagulants such as coumarin. Let's start with a concise overview of hemostasis. Hemostasis can be differentiated into primary hemostasis and secondary hemostasis. The aim of primary hemostasis is to stop bleeding, which is achieved by platelet aggregation in vascular lesions. A thrombus, termed white thrombus, is formed due to the absence of red blood cells. The thrombus is at risk of detaching and is stabilized by secondary hemostasis. In secondary hemostasis, coagulation factors are activated, leading to the formation of fibrin strands, which strengthen the thrombus. Because red blood cells become trapped in the fibrin strands, the thrombus is termed red thrombus. Secondary hemostasis is also called coagulation. Coagulation is followed by fibrinolysis. Fibrinolysis dissolves blood clots and initiates wound healing. Let's start with a close look at the first step of hemostasis, primary hemostasis. Primary hemostasis can be divided into vascular and platelet hemostasis. After vascular injury, smooth muscle contraction occurs within seconds in the vicinity of the lesion. Muscle contraction appears to be a reflex in response to smooth muscle stimulation. However, this process is not completely understood. The initial contraction of blood vessels lasts for approximately 60 seconds and is facilitated by substances released from platelets. Vasoconstriction directly reduces blood loss through decreased vessel injury and redirection of blood flow. In addition to reducing blood loss, vascular hemostasis has a second important function. Vasoconstriction creates increased shear stress in vessels. Shear stress is a term used in physics. Let's use an example for illustrative purposes. Shear stress occurs between two areas displaced parallel to one another. But where does shear stress occur in blood? Let's imagine a laminar flow, where blood flow is faster in the middle of the vessel than at the vessel wall. Shear stress is generated between these layers with different flow rates. Shear stress is greatest at the external vessel wall as a result of friction and decreases towards the middle of the vessel. So why is this relevant for hemostasis? The distribution of cells in blood vessels varies in accordance with shear stress. Large cells, such as red blood cells and leukocytes, tend to flow towards the middle of the vessel to avoid shear stress at the vessel wall. In contrast, the smaller platelets are forced towards the vessel walls, which favor platelet aggregation at the site of vessel injury. This is the second major effect occurring in vascular hemostasis. Let's briefly summarize the most important aspects of vascular hemostasis. After vessel injury, vasoconstriction occurs, which reduces blood loss and increases shear stress. Shear stress facilitates the accumulation of a large number of platelets. As we'll see in the next section, platelets adhere to vascular lesions, especially under high shear stress. Platelet hemostasis aims to seal the vascular lesion and stop bleeding. The first step begins with platelet adhesion. In intact blood vessels, platelets are separated from the endothelium by subendothelial connective tissue. If the endothelium becomes damaged, collagen fibers are released and platelets accumulate. For this to occur, platelets require von Willebrand factor, or, in short, VWF, as shown in the image. Von Willebrand factor is formed in endothelial cells independent of vascular injury and is secreted into the blood. If there is vascular injury, von Willebrand factor binds to collagen fibers. Platelets have a receptor for von Willebrand factor, abbreviated here as VWR, through which they bind to von Willebrand factor. This process is termed platelet adhesion and is the basis for the next phase, platelet activation. Details on platelet activation will be discussed in the next episode. But before that, let's briefly review a few relevant conditions. The first condition is von Willebrand disease, the most common hereditary coagulation disorder. Von Willebrand disease is caused by a defect or a deficiency in von Willebrand factor, resulting in impaired platelet adhesion and bleeding tendency. There are 3 types, each presenting with a different degree of bleeding tendency. Further information on von Willebrand disease can be found in its respective chapter via the link. In thrombotic thrombocytopenia purpura, or TTP, there is a pathological increase in platelet adhesion. We previously mentioned that von Willebrand factor is formed in endothelial cells. However, we withheld one aspect concerning its physiology. Von Willebrand factor is a large molecule present in plasma, and it is cleaved by a protease into smaller subunits. This protease is termed ADAM-TS13. The activity of von Willebrand factor is regulated by this process and prevents premature platelet aggregation in the blood vessel. TTP is caused by decreased ADAM-TS13 activity, which is mainly due to autoantibodies. When protease activity in blood is decreased to levels below 10%, this results in an increased length of von Willebrand molecules on which platelets adhere, leading to thrombus formation. Because many platelets are used in the process, patients usually have thrombocytopenia, which is associated with a bleeding tendency. This combined bleeding and clotting tendency also explains why the term thrombotic thrombocytopenia purpura is used. Let's move on to the third and final condition that we'd like to present, thrombocytopenia. A healthy individual has approximately 150,000 to 400,000 platelets per microliter of blood. If the platelet count falls below 150,000 per microliter, this condition is termed thrombocytopenia. Primary hemostasis disorders can result from thrombocytopenia. However, even with significantly fewer platelets, platelet hemostasis remains functional and can prevent spontaneous bleeding. Provided there is no underlying condition or vascular injury, for example as a result of trauma or surgery, a platelet count of approximately 7,000 platelets per microliter of blood is sufficient for an adequate balance. This means patients with a count of 7,000 platelets per microliter can be asymptomatic. However, invasive procedures should be avoided. Okay, so let's briefly summarize the 3 platelet adhesion disorders just mentioned. A dysfunction of von Willebrand factor and a deficiency in platelet